So, I'm starting today with a discussion about training seizure disorders with neurofeedback because I want to get this out there and get it posted. I'm going to do one on alpha theta 2 here coming up, just so people have some basics so that they don't just dive into things without really looking into it, which happens, not too often, but on occasion. And I get concerned because people will have somebody come in with a seizure disorder. They'll do a map and they'll just use a standard protocol from our protocol output, which is fine for most things, but you can't do that with seizure disorder. Seizure disorders is a special case. To some degree, OCD is too. Those two things really require special protocols and attention, but they're also two of the most difficult things to deal with. So I'm going to kind of go over seizure disorders and using neurofeedback with them. I'm not going to get into all the demographics and all the electrophysiology, and at the molecular and physiological level. I've done that before, but we've got a terrific presentation posted on seizure disorders by a couple of neurologists on the New Mind YouTube channel. That's their area. It's good to find out from them about that kind of stuff. And you can Wikipedia seizure disorders and find out, more of those other details. What you can't get is what do you do about it with neurofeedback and why are we doing it the way we do it? So I really want to focus on that concept, those ideas. So let's talk about where the idea of training seizure disorders with neurofeedback even came from. Originally came from Barry Sterman, and this is Sterman and Egner's article 2006. I must cite this thing at least once a week and sometimes more, and I keep telling everybody on the planet they need to read this article if they're in the field of neurofeedback, and read it at least 2 or 3 times because this kind of article requires that kind of training. Not just for training with people with seizure and epilepsy, but also to understand the mechanisms of action of neurofeedback, which are fairly well covered in this. Although I have to say Barry has a new book out. It's kind of hard to find. I wish he'd make it easier to get hold of, where he really goes into much more detail than I've ever seen about mechanisms of action with respect to neurofeedback. So, highly recommend you get this article. We post it fairly often. You can find it easily on the internet. Sterman and Egner 2006. Really important article where he describes what's been going on in research with neurofeedback and epilepsy, since the late 60s, early 70s. So there's 30 years of research on SMR and seizure disorder. And they're peer-reviewed studies. Most of them were spawned initially by Barry Sterman's research, and he began with cats and researching that at UCLA Department of Psychiatry. And Barry is a very meticulous, very conscientious scientist, and he does excellent research and excellent designs. This is not some guy who's vaguely familiar or did a one-off piece of research. This guy is top shelf, and he was funded by the federal government to do some of this research. But as you know, he started with cats and then demonstrated empirically that you can train cats with neurofeedback and alter their physiology and structure and function. There was no doubt about that. The research was irrefutable. It was replicated. Anybody who says to the contrary clearly either is not a trained scientist or has not read the research. That's the only 2 possibilities. If you read the research, there's no doubt there's 30 years of it. And it indicates that 82% of the subjects studied demonstrated significant seizure reduction with an average value exceeding 50%. Many of the studies also reported reductions in seizure severity. Approximately 5% of patients have experienced complete control for periods of tabulation up to 1 year, and that's been my experience. This has been true even with anticonvulsants were subsequently reduced or entirely withdrawn. Okay. Here is a list. This is from his 2000 article, I think, where I got the list of the studies and replications. See, these are not Barry Sterman only. They're by different people from different labs published in different journals. These are replications. This is what gives you true validity externally in research. Here's 1981 to 1996. They are, and this will be posted, but you can find it in the research articles. In the initial studies involving relatively small samples and pre-treatment baseline measures as a control condition, on average, 80% of patients trained at enhancing SMR amplitudes were shown to display significant clinical improvements. You would have thought that the neurology community would have rushed in. They were so intimidated, and the drug companies were so overwhelmed that they just blocked this in the journals. It's pretty well documented. It's a sad moment in science, and it will be remembered later on, and the people who blocked it will be remembered. These high success rates of SMR training were further confirmed in investigations that employed more elaborate controlled conditions such as non-contingent or random feedback. They did very good designs. In addition, a number of investigations employing ABA crossover designs, which is, a very high quality, high validity design, have emphasized the causal and frequency specific nature of SMR training by documenting symptom reversal when reversing training contingencies. And what that means is that they would train with SMR up and maybe theta down, and then they would train with theta up or alpha up or something like that. And people would get worse. And then they would go back and train SMR up and theta down, people would get better. And then they would go back and train them and they would get worse. When you do that with a fair amount of people, it's pretty hard to argue the case against it. In reviewing the data accumulated in these studies, Sterman found that 82% of 174 participating patients who were otherwise not controlled had shown significantly improved seizure control, defined as a minimum of 50% reduction in seizure incidence. I mean, that's excellent, with around 5% of these cases reporting complete lack of seizures for up to 1 year subsequent to training cessation. And that's been, like I said, consistent with what we found in our clinic over the last 20 years and the other clinics I've talked to. We conclude that the research literature reviewed in this article justifies the assertion that neurofeedback treatment of epilepsy seizure disorders constitutes a well-founded and viable alternative to anticonvulsant pharmacotherapy. So Rusty Turner, a neurologist, is doing this. He's on board, and so are many other neurologists, but they're a minority in the field, and there's a lot of bias that's unfounded scientifically, but doctors are not always the best people at evaluating research or doing research because that's not what they're trained to do. It's Ph.D.s who are trained to do that. Here's a typical seizure-related map from one of Barry's research articles. It's atypical slow or fast wave patterns may be observed. So not just slow wave. In some cases, these are accompanied by such transients as spike and wave discharge, sharp waves, or poorly organized high-amplitude events termed paroxysms, all of which should be noted but deleted from the QEEG analysis in order to focus training on the more stable background EEG. So several key things in here. This morphology is discussed in my presentation on artifacts and morphology that's up on the Umine YouTube channel. And this is fairly common knowledge you can find on any of the sites discussing seizure disorder. Honey mentioned on Monday night when we were discussing a seizure case, a very good site for investigating the details of this. It's very informative. There's several sites like that. And you can get that from her or from Rob, and I think we're planning to post that site name. But if you look at this map, this is from the Sterman Kaiser database, you can see the 5 to 7 hertz is very focused in the left hemisphere, and the 7 to 9 hertz. That 7 to 9 hertz is slowed alpha. The 5 to 7 hertz is theta. This is a very common pattern you see in seizure disorder. That's why Barry shows it. A lot of times these may be mid-temporal lobe focus in terms of the seizure activity. Often they can also be insular and they're fairly common too in focus. A lot of seizure activity emanates from temporal lobes. It's the area that's least regulated by the thalamic cortical loops and most vulnerable in head trauma and other similar related issues. And now you can have a focus for seizure all over the brain, but that's really a common area. Sterman says studies utilize magnitude and not power. And he says it is important, however, to point out that the power transform squaring of magnitudes is never used for neurofeedback treatment. That is Barry's carved in stone opinion. So I'm just putting it out there for you to think about. I know people have worked with seizure disorder and Z-score. They've gotten some results, but Barry is very biased against it. I don't use Z-score with seizure disorders because I have gotten negative responses, which I have never gotten from SMR training. So if there's a risk of a negative response with one technology and there's not with another, I prefer the more conservative approach because I've worked with people with seizure disorder a lot, and I know how terrible it is to go through those things, and I don't think it's worth the risk. So until somebody can do studies like Barry has and contradict what he's saying, then I'd be hesitant to go in that direction. Typical protocol delivered. Neurofeedback treatment involved the suppression of 6 to 8 Hz activity with the left anterior temporal site T3 while simultaneously increasing 12 to 15 Hz activity at the adjacent medial central site C3. Rewards were obtained only when both conditions were met at least a quarter of a second. Well, that quarter to half a second is standard in our industry on almost all the softwares. Barry was built, designed, and setting up his own equipment in the late 60s and 70s, so he is very down in the weeds on all of this stuff. You can see that what he's saying here, if you read it carefully in the context, is you should be training at C3, C4, or CZ, and in order to affect the activity at T3. He did 1-hour treatment sessions, were provided twice per week for the first 6 weeks, and then once per week for the next 30 weeks. Now, I had to get clarification from this directly from Barry, which I got a month or two ago, and he confirmed my reading. The patient described above completed 42 sessions, so that we showed you the map. That was the protocol that he used, and his seizure rate, which had previously averaged 2 to 4 a week, which is common, declined progressively after the first month or so of treatment to less than 2 per month. That is also fairly common in my experience. Some months into training, he was involved in a court case with serious personal implications. During these proceedings, his seizure rate again increased. This was to be expected. I repeat, this was to be expected, in Barry's opinion, due to the stress and related sleep loss caused by these circumstances, since seizure disorders are best managed but only rarely cured. I mean, this paragraph is brilliant and is a wonderful statement for all of us from somebody who's done this much research with neurofeedback, because he's confirming what we talk about all the time on our lunch and learns, and Rob and I talk about in our books and in our literature, is that stress can reduce the efficacy of training with neurofeedback, mitigate it, and Judy Lubar was saying the same thing from her research with Joel. This is really well established. This is the biggest problem you run up against with your clients, is they're expecting they can just continue on with their life with the regular stresses and strains, and that some intervention, a drug or neurofeedback or something, will magically allow them to continue living the lousy lifestyle they're living, get away with it, and get better. That's what people often think they're going to get when they come to a clinic, and it doesn't work. And then they'll blame you because it doesn't work. And I hear that all the time, constantly. And that's why you have to tell them up front the whole story. You know, you need compliance. But here, Barry's showing it really clearly, 30 years of really high quality neurofeedback research. So that is a very valuable statement for us to consider based upon his work. Also noted that Related sleep loss caused by these circumstances is a major contributor. I mean Martin has been yelling from the rooftops since we started inviting him in a few years ago. He's written articles on it. He has an evaluation tool on it. Rob does. We've been talking about this constantly, and all the research continues to support Barry's statement here. Why? Because Barry started out as a sleep researcher. He knows exactly the consequences. Medication reductions and confounds. Subsequent to this disturbance, his seizure rate again declined, and he experienced prolonged seizure-free periods. His medications were reduced. He was able to return to work and resume a more or less normal life. So they had to reduce medications. How many times do we talk about that with the other disorders? A follow-up QEEG approximately 1 year after the beginning of treatment showed no focal abnormalities and a complete normalization of quantitative EEG characteristics. So everything was done right here. This case was straightforward, was not complicated by comorbidities. So notice, he's saying, in his experience, comorbidities can really make things messy. You come in, somebody says, well, he's got an attentional problem, then you do a map and other things, you find out, oh, well, he's got gastrointestinal issues, he's got depression and anxiety. You've got a lot of comorbidities. It's not going to be just a 30-session neurofeedback training operation, or even 40 in these cases. It's going to take longer. If you've got complex trauma, you could be up to 50 or 60. So these are important lessons learned and written of years ago by Sterman dealing with just seizure disorder. Okay. Failed medications and their side effects. So those can have a very negative impact on what you're trying to do with neurofeedback. Behavioral or economic adaptations, in other words, money problems, or other disruptive factors. So Barry has already outlined all these factors as confounds. He's already built a biopsychosocial model back as far as the 1980s. It's all clear to him, and we haven't honored these findings in a lot of areas of neurofeedback. We're just trying to create better protocols or better equipment rather than acknowledging what the research showed. Okay, so after saying all this, I want to say, do not use standard 2-channel protocols. No, verboten, do not, nada, forget it. Don't do it. Everybody, do not use standard 2-channel protocols or anything else if you're going to be conservative in helping people with neurofeedback training. If you want to use innovative protocols, I recommend you have a medical degree and you're a neurologist. At that point, it's in your scope of practice and you can manage the liabilities. If you're a neurofeedback practitioner, you better be doing what Barry says to do. And again, come back to this point. Don't train at the seizure locus. Sterman trained this client at C3 because prior research showed that training at seizure focus, in this case T3, was not as effective. And this is straight out of his article, 2000 article, Weiler et al. Exploring the hypothesis that localized cortical activation was the operative factor in SMR training. In other words, that that you were calming down activity at the focal site, attempted enhanced or high-frequency activity over variable sites of identified focal abnormalities. Only 27% of these patients showed meaningful seizure reductions. I specifically asked Barry again a few months ago, is this your finding? That you should be training over the motor strip, and training over the seizure focus is not an optimal solution. And he said, yes, there's no doubt about it. He went on to cite that case and other things as well. So we're going to train SMR up and theta down for seizure activity. Now, if you have more delta than theta, it might be useful to train delta down. But usually training theta down also brings delta and any high alpha down on the left side. But more than that, Barry's research shows that training SMR suppresses low frequency alpha. So if you're training SMR up, you are de facto, if you read his research, there's no way to get around it. You're forcing the brain to reduce low frequency alpha activity if you're training SMR up. Then if you're training theta down, you're getting at any real theta component. So here's our NewMind screen for setting up a session. It's very simple. It's a one-channel protocol. Put in the name, select SMR up. Here it is, SMR up. Put in your location, C3, C4, C2, CZ, and then theta down. Simple as that to set up the protocol. So here's the locations. If you're not familiar, there's C3, CZ, and C4. To make sure everybody's on board with the areas we're talking about. No other place. Check for asymmetry for the dominant theta side. So you want to make sure that you're looking at the slowing here. You can see clearly is mostly on the left-hand side. Okay, so that's important to consider. So let's look at a couple of cases here. And this is an eyes closed seizure map. Okay, this is a case, 23-year-old male. He came into our office. He was having seizures at least twice a week, sometimes more. He tended to have them in the morning at 5 a.m. He'd wake up in a seizure, or his parents would find him in that condition. And that's not uncommon, as we talked about on Monday night. That 4 to 5 area is really a common period where the circadian cycles, you're at your physiological dip, and a lot of people have heart attacks and seizures at that time of day. Here is his power. We could be talking about magnitude or power, of course. Notice that delta and theta is at least 2 standard deviations above normal. In his case, it's more like 3 or 4. That we have some elevated alpha as well. Notice that the dominant frequency, the alpha, is slowed. Even the theta is slowed. This is all slowed alpha and theta. Delta's a little fast, probably because some of that's slowed theta. In this case, look, the slowing is predominantly on the left side. You can see that here, the red's on the left and theta. Most of the delta's there too. You can see the primary locations, but we're not going to train at those locations. We're going to be training, and I brought this up because you can see T5, T6 is the worst location in terms of focus. But we're not going to be training there. The compensation is greatest in delta. Notice that we've got a lot of hypoconnectivity in delta. We don't have good communication there, which contributes to the global instability. Here's the physiology. Not a bad physiology. I mean, if you add that up, that's way below 50. So, 23-year-old college student who wants to drive, having seizures frequently, comes in. When we first hooked him up on his first day just to monitor his EEG after we did the map, because we like to do heart rate variability testing and EEG monitoring just to get a sense of what we're going to be training. His theta and delta were up at like 70 microvolts. I mean, we're trying to figure out how the guy even walked into the office, and it really, you see that, you really wonder, how high delta and theta can be before people are non-functional. Here's this eyes open map. Notice we have even more delta and theta and alpha. So here was our initial training session. This is at around session 12. We had gotten it down a bit already, but notice his theta is at 30 microvolts, his delta is at 17, and this is kind of characteristic of his profile. He was a big diet soda drinker too. And so as we got into the session, there's session 20. Notice we're training SMR up and theta down. Look at the difference. His theta's up here. We're training down 5 sessions later. We got it down into this range. And that was really good. We got lots of episodes where he would only get it down this far and then it would go back up. So we were getting backsliding. We'd do this and then we'd get this. We'd do this and then we get this. Then we would get this. Here's session 40. Look at that. Then he'd come in and we'd be back to this. We're like, what is going on? Again, when you see that kind of backsliding, think confound. And, with seizure disorder, there's a lot of potential triggers, but we knew that diet soda was a trigger for seizure. I mean, it's in the literature. So we said, you got to quit the diet soda. When he did, we got down to there, and it pretty much stayed down to there. And so that's pretty awesome. SMR up, theta down. Here were the symptom changes he experienced. Notice these were a lot of the symptoms he had. He had a lot of anxiety and depression because having a seizure disorder when you're a teenager in high school and college is pretty overwhelming. But notice how much we brought down. I mean, he was up here with the problems, and his focus, concentration, his worry, all reduced in problems. Short-term memory reduced in significance, became more organized. I mean, this was the consequence of going from this to this using SMR and theta training. It's what 30 years of Barry's research shows us. This also reduces stress, improves sleep, and people heal more. By the time we got to this point, he had been seizure-free for a whole year. He got his license back. And his parents were saying, well, can't we do more to make him a better student? These are high achiever parents. And we said, there's a risk involved. There's no research on doing that kind of thing. And they said, well, we talked with him and he's willing to take that risk. And we said, okay, but we're going to go very slowly. So we started, based on the map, doing some 2-channel protocols frontally. And in about 2 months, he had another seizure. And we said, we don't think this is a good idea. So we went back to the SMR training, theta down. And it took us, right away, he started having less issues. But it took us a few months to be sure that he was seizure-free again. And we got a whole another year and passed it. And he was fine again. So that protocol is pretty specific. Now, here's Dorothy's map. She was somebody that we did pro bono. She didn't have any funds for this, and she had grand mal seizures. She was having them once or twice a week, depending. She was not on medication. She was not responsive to medication. She was just stuck. She was kind of like, well, neurologist said, you can't do anything, good luck, kind of thing. This was her map. You can see it's very similar in the sense that we have a lot of delta and theta and alpha. In this case, the theta is the highest, and dominant frequency is fairly normal. So it shows you it can vary quite a bit. Theta is a little fast, delta is a little high. It's really the magnitude that's telling us about this physiological condition. There is her morphology. I use her example quite often because she was somebody who I was able to capture paroxysmal activity in the office. And this is what it looks like. You'd see this pattern of normal EEG, and then you have the spike and wave starting to form and emerge. And you can see the theta is getting quite high at this point. Okay. This pattern is not commonly seen. It's rare you'll capture it. But this would be the pattern she had 24 hours before she had a seizure. So she was coming into me 2 or 3 times a week, and I was monitoring, and I could tell her when she was going to have a seizure, and then we would train her. But I also did a lot of heart rate variability training, and when I saw this pattern, I would have her go home. She was not allowed to do any excessive activity. She was supposed to rest, and she was supposed to practice heart rate variability. When she did that, she could fairly regularly abort a seizure. So patients with generalized tonic-clonic seizures may report having a pre-drome, which comprises premonitory symptoms occurring hours or days before a seizure, which means they feel kind of funny. Common prodromes include mood changes, sleep disturbances, lightheadedness, anxiety, irritability, difficulty concentrating, rally, and ecstatic feeling. Actually, have very similar um, prodromes to headaches. People have severe headaches that are not normal, whether they're cluster headaches or other kinds. You'll have these kind of mood changes or lightheadedness or irritability, and some people have a really elevated feeling too. So she didn't have any of this, so it's not necessary that you have these. She felt fine, no changes. I'd be looking and going, "How are you feeling?" She's like, "Feel fine." Here's the pre-map coherence. You see we've got excessive compensation in theta and alpha frontally. Interestingly, temporal lobe is not communicating well. A lot of right hemisphere slow wave activity. So we might tend to want to train in the right hemisphere. That's what I would do. Here's her recommended locations. Interesting enough, C3 did show up, and then C4. We trained at the right hemisphere, C4. Here's the post map. I mean, look at how much farther. We've gotten rid of most of that yellow. This was all yellow. And that was the change. Now notice dominant frequency did not change much. Asymmetry did not change that much. Coherence, however, you can see it's much more mixed. So magnitude is really the factor that tells you what's going on. And it makes sense. You want to train magnitude as a consequence. So look at the pre-post symmetry. And you can see clearly we've got significant changes in that. Minimal coherence changes. Here's pre-post. You can see that looks about the same. Very interesting. Minimal dominant frequency changes. They look very similar. Pre-post magnitude went from twice weekly to once every 9 months. Look at that change. Now, we didn't turn everything green. That's not your goal with neurofeedback. Your goal is to push the brain significantly in the direction, in this case, one standard deviation is significant, in the normative direction, and the delta normalized completely. That was sufficient to get this result. Pre-post percentage of change, 73% normalization. That's rare. I mean, that's rare, but that's what we got. So very good. There's the locations. These are the locations with the highest change. Notice C3 and C4 and T3. Those are the areas we would have wanted for training over the motor strip, and all these areas normalize, just like Barry predicted. And here's the acquisition phase, the pre. You can see she's up 20, 25 microvolts like that other client. And then just like that other, look, it's very similar to the previous one, down around 10, 12, where she should be. That's 40 sessions. Okay, so there's no research on Z-score and seizure disorder. It doesn't mean it can't work or it doesn't. It just means there's not. You're taking a risk, you're doing it. Check your scope of practice, etc., etc. I'm not willing to do this. I've had bad experience with it, and it's really that well confirmed. But Coben, Hammond, and Arns, as you know, wrote an article pointing out that a lot of this stuff with Z-score and Loretta is highly experimental and not well confirmed. Again, it doesn't mean it's not effective or doesn't work. I find Z-score is effective. I don't find it any more effective and sometimes less effective than standard neurofeedback, depending on the person and who's doing it and how well it's being used. It takes a lot of expertise and skill and special training. You talk to, if you want to get into it, then I would talk to Penny Jean Gracefire. She's the expert on this. Or Mark Smith when it comes to seizure. Coben was recently on and said that he'd had some good luck with neurofeedback and a research piece he produced on seizure disorder. This is the article that's kind of the standard on his type of research. This is available publicly on the internet, and this tells about the protocol he uses. It's very well researched, like Barry's stuff, not quite as well, but very well researched. And Coben's an excellent scientist and clinician, and very convincing evidence that this new special type of coherence, this isn't just regular, it's a very special type of coherence. He uses a specific algorithm, which is much more complex than straightforward coherence. And if you have access to software that does it, that might be something you'd be interested in trying. Again, I'm not doing it until I see a lot more research on this protocol and seizure disorder, but it looks promising. And it clearly is very effective with many other disorders. So something to look forward to. Many of the vendors, including NewMind, are implementing this in their toolbox protocols that you can use. So you'll be able to find this pretty commonly in most softwares within the next year, if not already. Okay, so that's my presentation on seizure disorder and neurofeedback. So we have some time to talk. That was my hope. It's not an exhaustive discussion on the topic of seizure disorder, but it covers the basics, and I want to get this out there so people can think from the basics and beyond. So with that, I'm going to